All right, thank you, Dr. Tornatore. I did realize I forgot one extremely important announcement. Thank you for reminding me. Our bathrooms, are out to the right, and then there's a sign, I think it says West Hall, and the bathrooms are there, okay? So if anyone needs to take a bathroom break, it's right there. We have some volunteers that can help if anyone needs assistance. Okay, for our next talk, this is actually a reminder if you look at the top of our agenda, it's really the Georgetown Multiple Sclerosis and Neuroimmunology Center. Because in addition to treating and diagnosing multiple sclerosis, there are a lot of other neuroimmunologic diseases that we focus on as well. So my next speaker is Dr. Benjamin Osborne. He's our director of neuro-ophthalmology, but also the director of our Neuromyelitis Optica clinic, and he's going to give us a little bit more information about that. I'm actually going to still stand up here. I'm going to be advancing slides for him, so that's why I'm still here. I will just say parenthetically, you may not know this little known fact, neuro-ophthalmologists are the most intelligent and most wonderful of all neurologists. So, all right.
The reason I wanted to talk about NMO is NMO, or Neuromyelitis Optica, is a disease state that overlaps with MS a lot. And a lot of times when patients come to us, we're trying to figure out, does the patient have multiple sclerosis or do they have NMO? And initially, it might be very challenging to figure that out. You can go to the next slide. So the goals of today's lecture is we're going to discuss what is NMO, what is neuromyelitis optica. We're going to talk about this blood test, the aquaporin 4 test, this NMO antibody. It really changed how we understand this disease, and why is it important to understand this, and how is NMO different from MS? So I like to start off with a case. A lot of times we like to teach our residents and students with cases, and this was a very informative case. So this is a 23-year-old female. She was having left facial numbness and loss of taste in August of 2012, and she saw a neurologist. An MRI of the brain was done, she had a spinal tap, and her NMO antibody test was done. And the white matter lesions were seen on the MRI, suggesting that she had multiple sclerosis. The spinal tap came back showing something called oligoclonal bands, which again suggests that she has multiple sclerosis. And the antibody test came back negative. So she was diagnosed with multiple sclerosis, and then she was started on Copaxone. And Copaxone is one of the drugs that we have available for treating MS. But after she started that, the next year she started having nausea and vomiting. And then it was getting worse a month later. And so she got another MRI of the brain. So we're trying to figure out why is she having so much nausea and vomiting. That's not a typical side effect of Copaxone. She had a new lesion. So she got IV steroids, which is what we typically do for what we think is an MS relapse. And she got a little bit better with the steroids. But then she got a repeat MRI. There was resolution of that lesion on the MRI. But then in March, she started having new symptoms, left arm numbness. She started having bladder problems. And she started having a lot of pins and needles type pain in her legs and arms. So then she got an MRI of her spine, and she had inflammation, something called longitudinal extensive transverse myelitis, which basically means she has inflammation of her spinal cord. That can be seen in MS, but sometimes we also see this in NMO. So they decided to repeat the blood test, and lo and behold, it came back positive. And this really changed her diagnosis, because you can get a false negative blood test with the NMO antibody, but when it comes back positive, that almost always means you have NMO and not MS. So that was very helpful and informative in this case. So, next slide. So what is NMO? So I talked a little bit about it, but I really didn't describe it. It's another inflammatory disease of the central nervous system. So it can affect your brain, it can affect the spinal cord, it can affect your optic nerves. And that's just basically what MS can do also. So you can see why it's confusing. MS can affect your brain, your spinal cord, and your optic nerves. And it's used to be thought to be a form of MS before we had the blood test. But now with the identification of this NMO antibody, we know it's a separate disease. So this was not a new disease. It was first described back in the 19th century by Dr. Devick. It was known as Devick's disease. And these patients had simultaneous vision loss and loss of control of their legs and arms. So they had optic neuritis and they had transverse myelitis. And so these patients classically, when I was in training, before we had this blood test available, unfortunately these patients were sometimes blind and either quadriplegic or paraplegic. So they were in wheelchair bound and severely visually impaired. But in 2006, everything changed. The Mayo Clinic discovered this antibody test that was associated with this disorder. And it turned out that this antibody test was very specific for NMO. So this blood test is called the NMO antibody. And what it does is it identifies antibodies that are circulating in the blood, and they bind to a water channel in the body called the aquaporin 4. It's not important that you understand all this, but it's important because the aquaporin 4 is in the central nervous system, and patients who have this antibody are very high risk for having this disease. But the problem with the test is that 10 to 40% of patients who have NMO will have a negative blood test. Like that case I showed you, initially her blood test came back negative. Some people will always stay negative. So it's a very specific blood test, but it's not very sensitive. So we also know that this antibody contributes to the disease. It's not just a marker of the disease, but having these antibodies actually lead to the disease itself. It's a very rare condition, much less common than multiple sclerosis. There have been at least 4,000 cases diagnosed in the US, but we think it's probably underdiagnosed. There are probably at least 500,000 cases worldwide. Like MS, and I've already said this several times, like MS, it's more common in women than men. And the age of onset is similar to MS, so usually 32 to 40 years of age is when people are diagnosed. It's a little bit more common in people who are from African, Asian, or Pacific Island ancestry or Caribbean ancestry, but we also see Caucasians with it too. So what are the core features of NMO? So patients can have optic neuritis, just like MS patients. They can have this transverse myelitis or inflammation of the spinal cord. They can have something called an area postrema syndrome. We'll go through this in a little bit more detail. This is where patients can have intractable nausea and vomiting or intractable hiccups, not just for a few minutes or a few hours, but lasting days or even weeks. They can have something called a brainstem syndrome, where they might have double vision or vertigo. And then they can have some very rare presentations where they might actually look like they have narcolepsy, or they can have other masses on their MRI that might even look like a tumor. So optic neuritis, well, the NMO antibody, I just want to talk about the NMO antibody a little bit more. So this antibody binds to aquaporin 4, and where it binds in the central nervous system will kind of lead to what kind of symptoms the patients have. So if it's binding to the optic nerves, which are the nerves connecting your eye to the brain, that will lead to vision loss or optic neuritis. If it's binding to the spinal cord, that will lead to transverse myelitis, which will lead to weakness or numbness in the legs. And then if it's causing inflammation in the brainstem, which is the lower part of your brain, connecting the brain to the spinal cord, that can lead to double vision and vertigo symptoms or nausea and vomiting. So optic neuritis, this is usually sudden vision loss in one or both eyes. In NMO, it tends to be bilateral vision loss, whereas at MS, it's usually in one eye only. And it usually gets better with steroids. We treat a lot of flare-ups of MS and NMO with steroids. But unfortunately, in this case, it can lead to permanent vision loss. And this MRI is just highlighting that this patient actually has bilateral optic neuritis. So both the right and left optic nerves are inflamed. We tend to think of NMO when patients have recurrent attacks of optic neuritis. But again, it can be confusing because you can get recurrent attacks of optic neuritis in multiple sclerosis. But when patients do have recurrent attacks of optic neuritis, even if they don't have any other symptoms, we'll test for the antibody. And about 50% of patients who have recurrent optic neuritis, even if they have no other symptoms, will test positive for this antibody. And this will have an impact on how we decide to treat these patients, because we know that these patients are at high risk for having future attacks, and so we'll want to put them on a treatment to try to prevent future attacks. And some patients might have several years between attacks. There are patients who've had optic neuritis, and then 10 years later is when they have their next attack. So there could be a long time period between attacks, just like in MS. Typically with the optic neuritis, patients will get pain on eye movement. So in addition to just having vision loss, they'll have a significant amount of pain on eye movement. And again, it's usually bilateral and a little bit more severe with NMO compared to MS. Unfortunately, with NMO, the vision loss can be permanent, even with treatment with steroids or plasma exchange. Some patients tend not to recover as well. So it's very important to diagnose this very early on and get patients on treatment if possible. Transverse myelitis. So this is inflammation of the spinal cord. This can lead to some of the most significant disability because when you get inflammation of the spinal cord, it can lead to problems with walking. It can lead to a lot of pain. The pain can be very intractable even after the patients recover from the weakness. So it can lead to paralysis of the arms or legs. It can lead to numbness in the chest down to the toes, bladder discomfort, bladder incontinence, and then neuropathic pain. The area postrema syndrome is very interesting. So this is pretty unique to NMO. We tend not to see this in MS. And this is a tip-off that we might be dealing with NMO when patients have intractable hiccups or intractable nausea or vomiting. They might end up seeing a gastroenterologist because they've had recurrent bouts of unexplained nausea and vomiting, and the gastroenterologist can't figure out why they're having this. And then when we get the MRI might show in the brainstem inflammation suggested that they have NMO. The brainstem syndrome is a syndrome where you can get the nausea and vomiting, but in addition, there's other parts of the brain and the face that can be affected. So you might get something that mimics a Bell's palsy where the face can be partially paralyzed. Double vision can occur, hearing loss, and even intractable yawning. Here's an example of a patient. When she looks to the right, she's seeing double. When she looks to the left, she's seeing double because her eyes aren't moving correctly together. Your brainstem is very important for controlling your eye movements, and so if there's any inflammation there from NMO, that can lead to double vision problems. This is a very rare case, but sometimes patients can get something called a diencephalic syndrome. Parts of the brain that control your sleep-wake cycle can become involved. You can actually get sleep attacks that can mimic narcolepsy, where patients just all of a sudden, they get startled and they have a sleep attack. So they can have excessive sleepiness. So patients who have this can have an MRI. If it shows this inflammation in that part of the brain, that could cue the neurologist to think about testing for NMO in those situations. And then it used to be taught when I was a resident that patients with NMO have to have a normal MRI. That was the classic teaching that helped differentiate it from MS. Before we had the blood test available, the thinking was patients can get optic neuritis, they can get inflammation in the spinal cord, but the MRI of the brain should really look normal. And then when the blood test became available, we started noticing when sometimes they have these spots on their MRI of the brain. It's become more and more obvious that a lot of times that the MRI of the brain is abnormal and can sometimes be confusing, and sometimes even look like there's a tumor on the MRI. So sometimes these patients even get brain biopsies because we're not sure what's causing these masses, and eventually that leads to the diagnosis. So in our neuroimmunology clinic, we see not just MS, we not only see NMO, but we see a whole host of other diseases that can mimic MS or mimic NMO. So clearly the most common disease that's going to get confused with NMO would be multiple sclerosis. But there are other autoimmune diseases that we have to think about. Lupus, sarcoid, a rare viral infection that can affect the spinal cord, HTLV1 or 2, lymphoma, a form of cancer. Sometimes will start off in the central nervous system. It's not common, but that's something we have to exclude. Behçet's disease is another very rare autoimmune disorder. Vitamin B12 deficiency, probably everybody here has had their vitamin B12 level checked because sometimes that can be associated or mimic multiple sclerosis or NMO. Neurosyphilis, so we check for other infections. And then ADEM is something we typically more commonly see in pediatrics, but it's an acute inflammatory demyelinating disease that can mimic NMO also. So for treatment, so the treatment's very similar to MS. If somebody's having a flare-up, we'll start off with steroids. Typically, we'll use IV steroids, so sometimes you have to come into the hospital if it's a severe relapse. If the steroids don't work, sometimes we'll have you in the hospital get plasma exchange or something called IVIG. This requires being in the hospital a little bit longer. Typically, for IVIG or plasma exchange, you might be in the hospital for up to a week. One of the key reasons we need to differentiate multiple sclerosis and NMO is because the treatments are very different. Some of the treatments that are available for treating MS have actually been shown to possibly worsen NMO. So there have been case reports of some of the interferons, for example, and some of the oral pills and some of the IV medications that we use for treating MS were given to patients who were thought to have MS. It turned out they had MO, and their NMO got worse. So it's very important to actually make this distinction because the patients, we don't want to obviously cause any harm. So the drugs that we tend to use for preventing attacks of NMO are a little different. These are autoimmune medications that are called immunosuppressants. You might have heard of some of these like Cellcipt or azathioprine. They're sometimes used in other autoimmune diseases like rheumatoid arthritis, or sometimes patients who've had transplants are put on these medications so they don't reject their transplants. And one of the drugs that we use a lot in our center is rituximab, which is an IV infusion. This depletes part of the immune cells in your immune system, which are called B cells. And by depleting those B cells, it hopefully will lead to a drop in those NMO antibodies and lead to less attacks. But in addition to preventing attacks, a lot of patients will have symptoms between attacks, and probably muscle spasms and pain are the most severe symptoms that patients with NMO suffer. And I think there'll be a talk a little bit more detail later on about spasticity, but some of the oral medications that we can use are gabapentin, which is also used for a lot of other neurotypes of neuropathic pain, carbamazepine, baclofen, which is a muscle relaxant, tizanidine, another muscle relaxant. I think you'll hear a little bit more detail about Botox or botulinum toxin injections. And then probably the most important thing that we use is physical therapy. and exercise. I can't emphasize that enough. That's true not just for NMO, but also for multiple sclerosis. Patients who have a lot of muscle spasms and pain, if they stay seated and they don't move around a lot, that can lead to a lot of worsening pain over time. So just making sure that you're moving your joints and moving your muscles can lead to a lot of pain relief in the future. A lot of research is being done on NMO, so I'm not going to go into a ton of detail about this, but there are a lot of trials going on across the country in NMO. A lot of these are looking at drugs that are similar to rituximab. MEDI551 is a little similar to rituximab, but it depletes other cells besides lymphocytes, something called plasmablasts. Plasmablasts are actually the cells that make the antibody. So the hope is by depleting those cells, that will help prevent attacks. Eculizumab is another antibody, and then tocilizumab is another drug that's actually on the market for other autoimmune diseases currently that might come on, is being investigated actively now in NMO and might be approved later on for treating this disease. And I wanted to end by just showing you there's a lot of research going on, but there's also patient support groups for patients who have NMO. Guthrie Jackson Charitable Foundation is a foundation that was started by actually a patient and her family. And she was diagnosed, I think, about 5 or 10 years ago. And they had obviously never heard of NMO before. And they set up this foundation to not only promote research, but to help education for patients who have this disease, who don't know much about it. Their families probably have never heard of it, and their friends have never heard of it. So if you go to that website, it has a lot more information about NMO, centers that treat NMO like ours, and a lot of the research that's being done about it. Also, a good resource is the National Institute of Neurologic Disorders and Stroke, which is part of the NIH. They have education not just about NMO, but about a whole host of neurologic diseases. And then there's something called the National Organization of Rare Disorders. Again, this is kind of a less common known disease, NMO, so it falls into the rubric of these rare disorders, so that's another good website to get more information. Unfortunately, I do have to leave early today, so I actually am going to take questions now if anybody has questions about my talk. The rest of the speakers are going to take questions at the Q&A session, but if anybody does have questions, I'd be happy to answer them now. Yes?
Are all patients who are diagnosed with multiple sclerosis tested for NMO?
So the question was,
If not, why not?
So the question was, are all patients who have the diagnosis of MS, are they tested to see if they have NMO? And if not, why not? I would say many patients are. There might be some cases where they're not, but I'd say most patients now, because the antibody test is available, a lot of patients are screened for that because we know that there might be certain patient characteristics about an individual patient where it doesn't really look like NMO at all, so they might not consider it, or it might seem unlikely, but I think most of the time now we tend to check that early on, especially if any patient who has optic neuritis or transverse myelitis that looks characteristic, or if they have some of those other syndromes that I mentioned, like the intractable nausea, intractable hiccups.
Do you have an average time between the onset of symptoms and when they seroconvert? Because I see that you have to test this person twice.
So the question was, how long does it take for patients to become positive? I'm not sure we know the answer to that question. We do know that some patients who test negative early on, if you repeat it 6 months or a year later, they will become positive later on sometimes. But a certain percentage of patients, it's not a perfect blood test, remain negative. I didn't go into it. There are other antibodies that are thought to be possibly associated with NMO, something called the MOG antibody. So sometimes we'll test for that. It's not clear if that antibody is actually causing NMO or maybe a separate autoimmune disorder. But it can be a challenging diagnosis if people are antibody negative because they still might have this disease. And so there are diagnostic criteria for NMO that we can use for the patients who are antibody negative to help make that diagnosis. Yes? So the question was, can you have both? I think the thinking is now probably not. Some people who may initially been diagnosed with MS, if their antibody is positive for the NMO, then they're probably thought to have an NMO, and probably your neurologist would probably aim towards treating with a therapy more aimed towards an NMO type treatment. If you do have questions later on that you think of, some of the other doctors can answer them at the Q&A session too, so you can write them down on the cards. If there's a question you think of in 10 minutes or during the break about NMO and I'm not here, the other doctors would be happy to answer them for you. Thanks.